Welcome to Dateline Health. This is Fred Lippman coming to you from Nova Southeastern University. And we're going to talk about something that we had a couple of programs over the last 6 months talking about spinal surgery, pain, intervention, things of that nature. And since this is your show, we listen to a lot of questions that you ask us. And we've been getting a continuum of questions about spine surgery, and particularly minimally invasive new procedures. So who would I ask back? A person that is setting a record today, Dr. Jeff Cantor. He has been on the show now the 7th time. It goes way back to the early 2000s, and he's all grown up. Look at that, with a new beard and everything. It's terrific. Anyway, welcome, Dr. Jeff Cantor, orthopedic surgeon, spine specialist. Sir, welcome.
Thanks, Fred. It's good to be here.
Good to have you.
Always
here.
good to be here.
And I guess I would say a new right-hand colleague in your practice, John Booher, who is a physician assistant. Welcome to the set, and thank you for working with Dr. Cantor.
It's a pleasure to be here, and it's a pleasure to work with Dr. Cantor as well.
Thank you. Well, Dr. Cantor, what's new in spine therapy?
Well, what's new is technology is starting to get to the point where we can actually reach some of the goals that we've always had in spine surgery, which is to do less destructive work, to do operations that truly can restore and regenerate more normal versus operations that fix one thing and potentially create other problems later. So there are ultrasonic techniques, there are image guidance techniques that actually can allow us to do operations that really can change the whole way that spine surgery has been done and will be done in the future. And that technology is available now, and it works. It works extremely well.
And many times, and maybe I'm sort of editorializing, how you will try to avoid putting the person in a situation where everybody wants to do surgery, where you carry people along, you do a lot of rehabilitation, you do, and I'm going to speak to John Booher for a minute, a lot of interventions before you actually do what you think has to be done. Am I correct?
Well, you never want to operate on somebody who can avoid it. And clearly, surgery is the last option. And we do have an aggressive non-surgical program. And I just had a gentleman just within the last couple of weeks came down from Ocala, was scheduled for surgery. We put him on a weight loss program, on a conditioning program, dropped about 35 pounds, got back in shape, altered his exercise routine, and pain's gone. And so we avoided an operation. But there's a large population that you can't avoid. They get to the point where they need something done. And I've been doing this for a long time. I've been with you for almost 15 years doing these interviews, and I've done almost 7,000 operations. And I feel that the whole way that spine surgery and surgery is done needs to be better. It's wrong. We do operations that do create other problems. And with the technologies and the tools that we had up until recently, this couldn't be avoided. With these newer tools, we truly can do operations that will fix a problem without creating other problems. And we can recreate a more normal situation as opposed to fixing one thing and then having other problems down the road. So spine surgery typically is designed to get the pressure off the nerves, and we've secondarily thought about function. In other words, if you have a shoulder operation and you have shoulder pain and you go to the doctor and he gets rid of your shoulder pain but your shoulder doesn't move anymore, clearly that's not a good result. Well, we have the ability in spine surgery now to do the same thing. We can fix the problem and still have your neck work and still have your back work and be able to resume activities that are pretty close to normal or normal versus do an operation that really does create such restrictions in mobility, multiple fusion levels, which are very often avoidable at this point. The healthcare system is getting to the point where we used to get paid for bigger procedures, and we still do, but it's backwards. We should get paid for better procedures. And these new operations truly have minimized the use of resources, have minimized the hospital stay, have minimized the use of narcotics, have minimized the operating time, blood loss. So these new operations really have gotten to the point where we can do a much, much better operation much more cost effectively. So we're at the brink of some dramatic changes in spine surgery and in other areas of surgery as well.
John Booher, you come into this situation as a colleague of Dr. Cantor's at the Cantor Spine Institute, which I think is still in the same place, isn't it, Dr.
That's correct.
Cantor? Give me the address again.
3000 Bayview Drive.
Bayview Drive, right. Just short of Commercial Boulevard?
Just short of Oakland.
Oakland, just short of Oakland Boulevard, between Oakland and Sunrise, correct?
Correct.
Right. I'm just thinking. The John Booher, physician assistant, you come with a whole background of long-standing involvement at Cleveland Clinic in Cleveland, and now you're affiliated with the Cantor Spine Institute. Talk to us about what you do.
Working with Dr. Cantor is an experience that I haven't had in spine surgery yet, and I've been doing this for almost 40 years. I'm seeing new techniques and new approaches to surgery that are truly fascinating to me. And when you've been around for a while, you think you've seen it all and learned it all, but this is a new experience. Working with him, I work with him in surgery, I work with him in the office, I work with him in the hospital, so I get to see a whole picture of how the patients are before they come to surgery, how they come out of surgery, and how they do after surgery and rehab and things like that.
You know, it's interesting to both of you, you know, if you just think back short, maybe 10 years ago, everyone who was seeking the best spine surgical intervention wanted it because they wanted to mitigate the pain. That was it. Today, it's not only mitigating pain, people are looking for function, for the opportunity to do things because they want a quality of life.
The whole idea is to be able to restore function. And what these new techniques do is allow us to do a procedure that just fixes what's wrong and leaves everything else alone. See, what happens in spine surgery is bone spurs form from arthritis. So as a joint becomes arthritic, the joint expands, it gets larger, and it starts to grow into the area that's normally supposed to be where the nerves occupy. And the nerves get pinched and they become painful. And in the process of getting the pressure off of the nerves, we have to remove important structures. We have to get into the spine and take stuff out that holds your body together. So when we have to take the stuff out, we have to rebuild it. We have to fuse it, put metal screws and rods, implants to rebuild the structure that we remove. The new techniques allow us to go inside the spine through tiny incisions and dissolve the bones, dissolve the bone spurs from the inside out, kind of like going into a pipe and cleaning out what's plugging up the pipe without shattering the pipe. So traditionally, tools are large, they take up space, and most of the tools spin. They're drills, they're burrs, they're like dental drills. These new tools vibrate. They use high-frequency vibration to pulverize and dissolve the bone. So we can use them right next to the nerve and even on the nerve. If you know how to use these tools, and the key really is knowing how to use them and practicing enough where you can use them safely around delicate structures. But if you know how to use these tools, you can go right next to the nerve, get the pressure off the nerve through tiny, tiny incisions. So number one, we're not destroying any structure, so we don't have to rebuild it. So we can avoid fusions almost 90% of the time. The blood loss is a small fraction. We haven't given a unit of blood in almost 6 years. Our blood loss average per case is about 25 to 30 cc's. When traditional operations, it's about 500 cc's. So it's like on these big gulp that you buy at 7-Eleven, and we're losing about a thimble full of blood. So the problems associated with big blood loss, big operations are avoided. So when we're going in, we're taking a stealthy approach to identify exactly where the problem is, fix it, and leave everything else alone. So we don't have to do massive operations anymore. And the technique has really delivered a product that we weren't able to deliver before. You know, lasers and all these things want to be able to get pressure off the nerves, but they really can't. This actually can do what a laser would like to be able to do. And John actually has had a lot of experience with laser surgery and has seen the difference between the new ultrasonic techniques and traditional techniques versus laser techniques, and it's dramatically different, that we actually can get the pressure off the nerves versus just kind of numb nerves temporarily. I've done, as I mentioned earlier, I've done spine surgery for almost 26 years and done almost 7,000 cases, and I taught the old techniques. I have a lab in my office that's a cadaver lab that's for teaching doctors. And 15 years ago, I used to teach these cervical screw systems and these fusion systems. And what I found was that when we did these operations and felt that we were doing a great job, and we were doing a good job because we were keeping people walking, but when the patients came back 2 years after the operation and I asked them, would you do this again and are you happy? Uniformly the answer was no. They wouldn't do it again, and they wished that they knew what the disability was that they were going to experience by having a multiple level cervical fusion or by having the screws and rods in the back of the neck. And as a surgeon, we need to listen to our patients. I've had 3 back operations, and I think before you should be able to do an operation, you should have one yourself to really understand what it means to be on the wrong side of the exam room. And I get what it takes to go through an operation and to really get better. And what really has to happen is operations need to be done better. Instead of doing an operation that 5 years after the surgery the patient said they wouldn't do again, we need to develop techniques and push technologies that can make that patient say, I would do this again. And right now we have about a 93% rate that at 2 to 5 years out, patients say that they're glad they did it and they would do it again, versus with the traditional techniques, they say that even though they're still walking, they have enough discomfort or disability that they wish they had known because it may have altered their decision. So we really have to be critical of ourselves and look at what we're doing and do a better job. Interestingly, I had one of these serendipity events where about 6 years ago I fell off my bicycle. I was training on a bike and finished a ride and wasn't paying attention, bumped into a guy in front of me and fell off and broke my arm. And I had a surgery that took me out of work for about 3 months. And I was using these ultrasonic tools and some of these image guidance tools before that, but I really wanted the time to be able to develop these techniques. So 2 days after I had my wrist surgery, I went upstairs in the cadaver lab in my office, got a whole big boxes of models. We've got the image guidance systems and all of the stuff that was necessary to do these operations, and I started practicing. I started working on these new tools, working on models, figuring out the process and the technique to do these operations that I've always wanted to be able to do. And it was the most positive thing that's ever happened. So a broken arm turned out to be something that's completely changed my practice. And interestingly, this technique has been looked at by some of the very big spine companies, and they've approached me and said, this is where everybody needs to be on a 5 to 10 year down the road basis. So this technology is going to be where spine surgery is done across the world once we get to the point where we can train enough doctors to be able to do these techniques and to be able to have the understanding of the process of how to isolate problems and how to preserve structure. So that broken wrist completely changed what I do. I haven't done a traditional operation in almost 6 years now. I have not used the drills and the traditional tools since that broken arm gave me the opportunity to learn how to do these operations differently.
John Booher, you've been in the world of spine surgery now, and you say 40 years plus, but you're in the OR with Dr. Cantor, or you're in the office, and I'm sure you're involved with the care and rehabilitation of your patients. Give us some perspective as to what you are going through at the present time.
It's interesting because, as I said, you get to a point where you think you understand and know how the patient's going to react. Looking at some of these techniques, and I think Dr. Cantor will remember one of the first times I ever scrubbed in and saw him do one of these surgeries. I was just flabbergasted. I said, we've never been able to do that. We've never been able to gain that kind of access. And all of a sudden, this is really, really cool stuff. To be able to preserve normal tissue and still deal with the underlying problem, decompress the nerve, and get the patient moving again. I'm seeing patients that routinely are 1, sometimes 2 days in the hospital versus 4, 5, 6 days and struggling. When I see patients post-operatively, they're up and walking, and the hardest thing for me to do is to convince them to not be more aggressive in their exercises or in returning to golf or tennis until things heal. They feel that good, and I think that's a real big plus for not only for us but for the patients.
Yes, no question. Dr. Cantor, again, I was trying to think. You've been here so often that I can't remember everything you said. Mostly everything, but not everything.
Remember pretty much everything.
But we spoke at one time about, a long time ago, about these interventions. At that time, a lot of cutting, a lot of sawing, they might have been minimally invasive in a sense, but not really, and the creation of a lot of scar tissue. Do I assume that these new techniques mitigates that problem?
The new techniques are a small fraction in magnitude compared to traditional techniques. So the tools don't structurally alter as much as the old technique. So scar tissue, things like that, anytime you make an incision anywhere in the body, you're going to have scar. The more you do, the more scar you're going to get. There's other ways to alter the formation of scar. We've looked at techniques after surgery as far as how people move, how people, when the body has an area that's been worked on, the things adjacent to it are going to stick together. So what we want to do is, number one, don't cause damage in that area. Heat, thermal injury causes damage. Lasers, using hot type techniques, using cautery, things like that, close to nerves causes a lot of scar tissue. So using these techniques combined with a lot of understanding of why scar forms and how to prevent scar, we've developed ways to dramatically decrease the problems associated with scar tissue. So this isn't just about one tool. This is about having years and years of experience and looking at every mistake that I've ever been involved with or I've seen from anybody else do, and try to forensically understand what caused that problem and aggressively try to change it. Look at why wounds don't heal well and understand that nutrition pre-surgery, nutrition post-surgery is very important in allowing patients to heal without problems like difficulty for the wound to close or wound infection. So it's not just using one tool, it's using a whole process and a whole paradigm change for looking at an operation from the preparation before, executing the procedure during the operation, and also after the surgery having a system that decreases risk at every possibility we can. So the ultrasonic tools are just a way to do surgery smaller. The process is to do surgery safer, less scar tissue, less infections, less blood clots, less pulmonary embolus, less heart attack, less stroke. And by really following strict protocol and by following and making patients follow strict protocol. Patients need to be involved in their treatment. If you take somebody to the operating room that's nutritionally not prepared, they may get a wound infection with a rate that can be 10 times higher than that same patient who's been prepped nutritionally before their operation. Patients need to understand what they're going through, and they need to have an honest understanding, and their goals need to be clearly defined, where they tell us what they want to accomplish and we honestly tell them whether we can reach that goal. And that's when patients become happy, is when they said, I wanted this, we were honest about it, and we achieved that, versus I wanted something up here, I really didn't know that we can only deliver down here, and now I'm not happy with my result. So there needs to be a very open, clear discussion that takes time to understand what the patient needs to do themselves, understand what I need to do, and to really walk them through a process that is truly different. The most common reason for a post-surgical wound complication is pre-surgical nutrition. So if we look at the cost and the morbidity, the problems for patients associated with getting a wound infection, we realize that that's a problem. And if we look at why people get wound infections, it's usually related to their ability to heal their wounds. Well, that's the ability for their immune system to function normally and for their body to heal normally. That's all nutrition. So before surgery, we go on a 6-week prep plan where we boost their protein, we boost their what's called phytonutrients, which are natural vitamins, and we give them the opportunity for their body to really be able to heal. And what's fascinating about that is a lot of our patients start these diets, and then 5 years later, their surgeries past 5 years, and they come back and I say, Doc, I'm still doing this diet. They lose weight, they feel better, they have more energy, they get sick less. This is all about boosting the body's natural defenses, and it makes a difference, and it's important. So I've myself studied pre-surgical nutrition, what nutrients are necessary for healing, and that has to be adjusted for folks that may have kidney disease and diabetes and things like that. But most of these nutrition plans are very good for folks who have nutritional problems like diabetes. It will decrease their blood sugar loads and things like that. So pre-surgical preparation is a number of steps. Blood clots is the most dangerous thing that can happen after an operation. That's why people die in about 1 in 4,000 cases. Blood clots are very often preventable. They happen from inflammatory foods and inflammation in blood vessels, and they happen from dehydration. So you can hydrate to have patients drink 80 to 100 ounces of water a day. You have them avoid red meat, fried, barbecued foods which cause inflammation. And prior to their operation, even if they're uncomfortable, they should be exercising. And you need to pay attention to these things because you have to identify this patient at risk and mitigate that risk before they have a blood clot and die after an operation. Every opportunity to do better should be exploited. And if you do everything you can and your results aren't perfect, it doesn't make us happy. But we do feel we did everything we possibly could. But if we're doing procedures and we're missing the opportunity to improve your immune system before surgery and you get a wound infection, that's when we want to kick ourselves in the butt. Say, why didn't we just prep that before? And
who does that consultation? Does it come directly from you, or does it come from John, or both of you, or what?
I have a whole preparation staff in my office. It's called our Patient Advocate Plan.
Right.
So I have 2 assistants, John and Patrina, who's my PA. Her entire job is to evaluate patients and do a healthcare analysis. We do nutritional counseling. We look at all of their past medical history. We make sure that their history is correct. We coordinate their cardiologist out of the hospital with a cardiologist in the hospital. So we make a seamless transition across the whole healthcare spectrum. It's a laborious project. It's an expensive process, but it works, and our results have shown that we really do have objectively measurable outcome differences that have shown that this system does work. Our numbers in the hospital were about $12,000 to $17,000 cheaper per case based on the fact that we use less blood products, we have less perioperative complications, our hospital stays are less, our anesthetic costs are less, our OR time is less, our post-surgical narcotic use is less because the pain's less. So the hospitals are looking at this saying, wow, how are you making that much of a difference? And the difference is preparation, preparation, preparation. In other words, the operation is thought out before. It's thought up before I make an incision. I draw on a whiteboard exactly where these cuts are going to be made. We don't go in and start working and kind of figure out where we are. It's all designed before we make an incision. So it's really about methodically preparing to be successful.
So John Booher, you observe all this while having used your many years of experience. Give us a view of what you feel like and how you see what you see.
Well, it's very obvious to see. Dr. Cantor's passionate about doing this, and when I first started to work with him, looking at all of the other spine surgeons I've worked with in my past history, no one had talked about nutrition. No one spent that kind of time talking to the patients about preparation and doing that, and so I thought that was a very strong positive thing, especially when I saw the patients post-operatively. When you see a patient that you would think was going to be hospitalized 3, 4, 5 days, and at 2 days they're up and they're moving and they're feeling good, and at a week their wounds are healing nicely, there's no signs of inflammation around the wound, it makes a big difference. I mean, I agree that technique by and far is a large part of this, but preparation plus technique plus I have only seen 2 physicians in my whole career that have spent as much time with a patient talking to them about what they're going to do and how they're going to do it, and at the same time listening to that patient and getting a feel really for what's wrong, for what's bothering them. When we walk out of that operating room, you feel like we did a really good thing today.
We're going to leave this show, we've gone down to the last 45 seconds, on that very high note. I wanted to bring you back because, once again, you brought us new information, and I want to thank you. John Booher, welcome aboard. I know you've been here a while, but welcome aboard. It's the first time that I've had the opportunity to meet you. And Jeff Cantor, what can I tell you? I mean, other than the fact that you've grown a beard, you haven't changed much.
Neither are you, Fred, so.
Thank you. But thank you very much for your constant view of the patient, which is, in my mind, has always been the primal focus of your activities. I know that you love to do things correctly and appropriately, but you've always had the patient in mind, and that's why we appreciate you coming back to tell us how you're caring for that patient. So thank you very much. Folks, I hope that you received some very interesting and sometimes, I think, almost exciting information about spine surgery. You've had a lot of questions about your back pain, your leg pain, your neck pain, et cetera, et cetera. Well, it all emanates from the spine, so we try to give you some information. Remember, this is your show, so if you have any questions, you have any comments, there's an email address and a telephone number. And as I always tell you, take good care of yourself. It's up to you to take good care of yourself. This show comes to you from Nova Southeastern University. My name is Fred Lippman. Until next time, see you.